Thank you, Holly. Now I have a question for each of the four panelists that have just presented. First for Jan. Do you have any idea of the impact of your community-based experience on the professional career choices of your students?
Well, as many countries, also Belgium faces a problem to recruit people for primary healthcare and family medicine. So we integrated this experience early in the curriculum together with other experiences. On the first year already, our students go to the community to have a clerkship in family medicine. In the second year, they have a 2 weeks assignment where they are in a community-based nursing home. So then later on, they have clerkships in family medicine, and that's for all students, also those who want to go for specialty training. What we observed in the last years is that during the last 5 years, in the whole of the region of Flanders, so Ghent University, together with the 3 other universities, has managed to double the numbers of graduates that go for family medicine training. And that's, I think, a quite important thing. We should not only relate that to the efforts that we made with all the other universities to have more community exposure. Also, of course, there were things of improvement, also of the position of the family doctor in the health system, and also a better way of payment for trainees also contributed to that. But I'm quite sure that also the efforts we do to give early community exposure for students may influence their career choice. And we see that when we measured it over the different years, we see this orientation that more students are going for family medicine and primary healthcare.
Thank you. Thank you. Next for Linda. What strategies have been incorporated at the Pacific University Interprofessional Diabetes Clinic to maximize interprofessional education and collaborative patient care efforts?
Well, at the IDC, the commitment to IPE and collaborative patient care has been very purposeful and very inclusive. So as mentioned in my remarks, students from more than one healthcare discipline are in the room as the patient is cared for and examined. One student, irrespective of their discipline, accompanies the patient as they receive services from the different disciplines. As mentioned, there's a true commitment to involvement of the patient care coordinator as a key member of the team. Obviously, that individual is pivotal to looking at consistency, coordination, outcomes, and quality of the care. And last but not least, the model includes a true shared team-based approach to decision-making to ensure the patient receives the best quality of care, but also that the patient is a partner in their healthcare efforts.
For Rob, how are the services of supervising integrative practitioners and their student interns underwritten, and who pays for or supports the provision of these services?
In general, these services are all paid for by the institutions, in other words, the integrative and alternative healthcare institutions. So in the clinic, such as Venice Family Clinic, the Venice Family Clinic is not compensating the salary of the visiting licensed practitioner. In the Toronto situation is the same. The Toronto Clinic is not allowed to collect fees from their patients. So basically these are self-funded. And in fact, one of the reasons that I have found this to be an interesting area is that of all the ACAC affiliated institutions in the United States and Canada, there's a tremendous amount of community-based care that's going on that is essentially invisible. It's not being, there are few, if any, philanthropic groups that are underwriting this. There are few, if any, grants. And part of that is perhaps because we have not promoted the fact that all these exist. And so talking about it today and future project is to really try to assess all of the different types of programs that we have out there. And eventually we hope attract some attention to get things underwritten, as I see that so many of the other things in conventional medicine and also in even integrative healthcare that is, say, medical school and university based are often very heavily endowed or granted, and ours aren't. So that's something I'd like to see happen as we gather more information and prove their worth.
Thank you. And Holly, you've discussed the impact on the learner. How have the caregiver interviews impacted the caregivers who participate?
Well, that's a great question, and one that we're currently asking ourselves right now. I think the emphasis of the whole project up until now has been focusing on the impact on our community partners. And they've been speaking for the caregivers, but we realize that we need to speak more directly with the caregivers. And we're currently in the process of having focus groups and meeting with the caregivers, which is very complicated due to their schedules as well, to identify any unmet needs that the community partners may not have shared with us or that we could help with and assist so that it continues to be a two-way conversation and a relationship.
Thank you.
Thank you.
Thank you. Please join me in thanking the panel. Our next panel will now assemble, and there will be 3 speakers on this panel, and the topic, the overall topic of this panel is community-based health professions education of students in medicine and in nursing. And our first speaker will be Rick Kellerman of the University of Kansas School of Medicine in Wichita. Rick.